Hello, everybody, and I'm honored to be doing this. And we're going to break multiple times during the presentation for some questions and answers, and then leave plenty of time for discussion at the end. I wanted to start out with a little vignette. I do that because in part it's interesting, and in part it gives latecomers a chance to join without really missing part of the presentation. So when I was in medical school many decades ago, this might have changed, but I would tend to doubt it. I was taught that lawyers are evil. All lawyers do is sue us poor, innocent doctors undeservedly for things we haven't done, and we have to alter our practice because of you guys. And again, I professionally grew up with this notion: avoid lawyers whenever possible. And then about halfway, actually less. Then about 30 years ago, I was recruited to be head of child psychiatry at Upstate Medical School in Syracuse. And soon after, maybe about 6 months after I got there, I got a call from the associate dean of the medical school, who I sort of knew socially for and said that the Syracuse University Family Law Clinic was representing a client, and would I be interested in being the expert witness? And I was immediately interested, and I said I would do that. And the case involved a child who was in pre-detention. I forgot what the delinquency charge was, but the kid was in pre-detention. There was never any allegations of abuse. The child hadn't had his day in court yet, so he wasn't guilty of anything. And the pre-detention center put him on 2 different psychiatric medications. Father, who never lost custody of the child, and again, there was no even allegation of abuse. The child's father objected to the medicine, and the agency said, tough luck. We're putting, our psychiatrist determined you need this medicine, and you have no say in the matter. At that time, New York State did not require parental consent. And many states, even today, don't require parental consent. Child developed some side effects. Father was very unhappy. The case was in Rochester, the next metropolitan area in upstate New York, over west of Syracuse. Father also was did not have a lot of financial resources, because I think he had a lot of resources in the effort he put into this. Somehow he called the Syracuse University Law School Family Law Clinic, who agreed to represent him for free and pay all the expenses of the trial. I examined the kid, reviewed the records, and wrote a report about what a bad decision the medication was, and how the medication was not indicated and really was very bad practice. And in addition to that, I wrote about how a parent, even if the medicine were indicated, which I thought it wasn't, I thought it was quite poor treatment, there's always alternatives, whether it's cancer treatment, heart disease treatment, diabetes. There is nothing in anything in medicine that I know of where there only is one treatment and any other possibility is unreasonable. So there always are alternatives. And the kid wasn't assenting, which creates huge problems, not just with compliance, but also the minute the kid leaves whatever facility he's in, and I've seen this, hundreds and hundreds of times, they stop the medicine. So why give an intervention that by definition can't be helpful because the kid's not going to be compliant? And clearly the parent should choose what treatment they want for their child, unless they've been deemed as incompetent, or parental rights have been terminated, or that their objection is unreasonable. And as we'll talk more, over 90% of the time in the reviews I've done for agencies in New York and out of state, most parental objection to psychiatric medicine is quite reasonable. So the case went to trial. The judge found for the father, but issued an excoriating opinion against the Department of Social Service for the county that Rochester is in. About giving medicine without parental consent, and B, an excoriating opinion for DSS in giving medicine where clearly the risk outweighed the benefit, and this really was not a evidence-based treatment or even community standard. All they were trying to do was medicate the behavior that the kid exhibited when the kid came into the center, and the kid exhibited it because he didn't want to be locked up. And he wasn't even tried yet. This kid was guilty of nothing, and put on medicine because he objected essentially to being in a residential treatment pre-detention. So this was the first case in New York State where a county judge said there should be parental consent and that DSS should be held to certain reasonable standards of care. By coincidence, or maybe partly propelled by this first decision, within the next 6 months, 2 other district courts in New York issued similar rulings excoriating the local DSS for pitting kids on medication that might be harmful when there were other reasonable treatments, and for denying parents their right to consent when parental rights have not been terminated. Now there were 3 precedents in New York State, and this forced the New York State Department of Children and Family Services to change their policy. They've now lost 3 times in 3 different jurisdictions. And because of this, New York State developed one of the first policies in the country. And this is back now about 20, 30 years ago, requiring parental consent both for juvenile justice placements and for kids in foster care. So what I learned from that was that, in fact, lawyers advocating for kids and parents can change the system and change it fairly dramatically. Litigation is a powerful tool to change the system and has had way more effect on changing the system than the hundreds of speeches I've given to psychiatrists about why they should prescribe less medicine. So this really went a long way to correcting this early prejudice and bias that I had, that all lawyers do are sue poor innocent doctors. you all have a huge role to play in advocating for kids and parents around these issues of over-medication. So we know from multiple studies that kids in the juvenile justice system and kids in foster care, and in many jurisdictions, those two systems are somewhat merged, are given way more medication than necessary. We know that from a number of studies. One is we know that, and this relates to a webinar I think that's going to be offered in the future using a racial lens to look at these issues. We know that kids with private insurance are medicated way less than kids on Medicaid. And we also know the disparity between Medicaid and private insurance for racial, ethnic, and minority groups. So clearly, poor kids and kids from minority groups are medicated way more than generally white kids from white families that have private insurance. Then we know that even within the world of Medicaid, kids in the child welfare system and kids in foster care and kids in the juvenile justice system, where the state is playing a role in decision-making, and it's not just between the parents and the provider, are medicated way more than other kids within Medicaid. And again, with each cut, you get more and more children of color, children of minorities, children of ethnic groups, and the data, and we lastly know that the amount of medicine given to kids in child welfare, juvenile justice, and foster care is way beyond what we know about the incidence of the mental disorders that would necessitate, or at least make those medicines reasonable treatments. So if ADHD occurs in 5% of the population, you can't explain why ADHD medicine is given to 10% of kids in foster care, other than it's given to control emotions and behaviors that adults don't like, as opposed to really being given for a disorder where there's evidence that the medicine helps the disorder. Even more so for antipsychotic medication, which we'll talk about a lot more, given for so-called mood disorder and irritability. Here we have the most dangerous group of psychiatric medicines, looking at both short-term and long-term risks, being given multiple times more than the disorders they're indicated for, by true bipolar disorder or schizophrenia. So we know with real certainty that these medicines are given way more than anybody could justify. So what are the causes of over-medication? First and foremost is these kids have a lot more reason to be angry than the average expectable kid, but adults don't like angry kids. Foster parents don't like angry kids. Residential staff in juvenile justice centers don't like angry kids. They also don't like oppositional kids, and oppositionality really isn't a psychiatric disorder that should be medicated. Kids that are very angry misbehave more because they're angry. So they tend to be more oppositional, they tend to fight the rules, they tend to have aggressive outbursts. They mouth off a lot, which in reports is called aggression. For me, aggression is when you punch somebody. But we've gotten to the point where, if a kid verbalizes something an adult doesn't like, and the kid is in that person's custody, that kid is now labeled as aggressive and needs something to control its aggression, as if cursing really is dangerous or saying oppositionality is really dangerous. So the kids we're talking about exhibit emotions and behaviors that are not psychiatric illness. The anger itself isn't even abnormal. The behaviors are maladaptive, but again, aren't major psychiatric disorders. But adults don't like that. They don't tolerate that. So they demand, whether it's the foster parent or the residential caretaker staff, they demand, or the teachers, they demand that the kid is being put on medicine. Now, when you're in these systems, you tend to lack a true advocate. First, and this is why we have the difference between kids in Medicaid, although they might come from similar socioeconomic circumstances, they live at home with their parents. And their parents in general, are fantastic advocates for their kids. So if a parent on Medicaid is, the teacher's saying, take your kid to see the psychiatrist, they go see the psychiatrist, and the psychiatrist recommends treatment that the parent doesn't understand or doesn't think is correct. The parent is the advocate and says, what alternatives are there? Or I don't want this treatment for my child. What alternatives are there? Or you've told me this medicine is going to make my child overweight. I'm not willing to tolerate that side effect. The risk outweighs the benefit. In the child welfare system, kids really don't have advocates. Their parents are dismissed and demeaned and not respected. In fact, I've seen all over the country where parents don't consent, they're threatened, either overtly or subtly. If you don't sign the consent, that's medical neglect. It's just going to delay your getting your kid back. If you don't sign consent, it just shows that you're an awful parent and you're not going to ever be able to take care of your kid. And this is when the parent's objection is absolutely perfectly reasonable. And any of you or I could make the same objection. So parental advocacy is dismissed. The caseworker, in fact, is as interested in controlling the child because they're being told the kid has to be controlled by the foster parent or the residential staff. So unfortunately, in the real world of child welfare, which really includes both foster care and juvenile justice, the only true advocate for the kid frequently is either the lawyer for the parent or the lawyer for the child, or the CASA worker sometimes, if they're trained correctly. So the lack of true advocacy means nobody is asking the right questions, no one is objecting to the treatment. The second cause for over-medication, which I already alluded to, is really the mislabeling of normal, albeit intense, emotions as psychopathology. And that happens, clearly with anger. A kid who, in the middle of the night, the caseworker for DSS or whatever it's called in your jurisdiction, knocks on your door and pulls you out of the house, maybe does a strip search, searches the house, opens all the drawers. The parent is unable to object for what clearly is, in my opinion, an illegal search. And you couldn't do that search if they were really, if it was a criminal matter, because then they have rights. But for child welfare, they don't have rights. Is pulled out in the middle of the night, put in sometimes a hotel or some kind of dorm because they don't have enough foster homes, could be separated from their siblings. So these kids have every reason to be angry. The anger's a normal emotion. Although adults don't like when kids act out anger, anger is normal. Every single one of us have experienced anger. And yes, these kids might have a problem in that they haven't developed adequate ways of coping or expressing the anger. So they do have more maladaptive behavior, but maladaptive behavior in and of itself is not mental illness. And we constantly name things in a way to mislabel them as psychopathology. Another example is a child has been exposed to multiple episodes of domestic violence. The child is in the foster home. The child, in many of our systems, especially in those first few weeks, you get almost no contact with your parent. You don't get a visit, you don't get phone calls. The child is worried. Notice I didn't use the word anxious because that already tilts the scale. Anxiety is a psychiatric disorder. Worry is a normal human phenomena that, again, every single one of us has experienced. The child is in the foster home and is worried whether his or her mom is alive, because the child knows that mom's current significant other has frequently hurt mom and beaten her. So this child is worried, and then constantly nagging the foster home. I need to call my mom. I need to call my mom. And then the kid is dragged to a psychiatrist, and that's called anxiety. No longer is the kid realistically worried about mom's safety, because that's the reality of the kid's life. Now the kid is anxious. They forget that it's realistic, and therefore has anxiety disorder and is put on an anti-anxiety medicine. I review hundreds and hundreds of reports for all sorts of different kinds of groups. I don't see the word sad or unhappy used anymore. We use jargon, and the jargon has almost invaded normal everyday English. Depression is the punchline. If you've done a careful evaluation, depression is the conclusion. It's the last line in a report. It can't possibly be the first line in the report, because you don't know that that's your conclusion until you've done your evaluation. But in so many psychiatric reports that I've seen, the first line of any medical note is chief complaint. Basically, why are you here? So the kid or the foster parent, because again, we've been so exposed to the system that we do this unconsciously. So instead of saying the kid is here because the kid is sad a lot or unhappy a lot, we say the kid is here because he's depressed. But we don't know that until we've done the evaluation. I never see the word sad or unhappy used. So once you start out with the bias that the kid's depressed, it makes it all the much more likely that you'll not conclude the kid is sad and unhappy because of the reality of the child's life. Every one of us gets sad and unhappy because things happen in life that make average human beings sad and unhappy. But we dismiss that these kids could be like us. We make them as others, and we over pathologize the sadness and the unhappiness as depression. The anger gets over pathologized as mood disorder, or even worse, manic depressive or bipolar disorder. Or now we have a fancy new term for that, DMDD, dysphoric mood dysregulation, disruptive mood dysregulation disorder. All a fancy name for anger with behaviors we don't like. And of course, any kid that twitches a muscle has ADHD. Now, ADHD is a real psychiatric disorder, but we're constantly mislabeling these kids with psychopathology. So as I alluded to, this mislabeling is really misdiagnosis, wrong diagnosis, and multiple diagnoses. I've seen, hundreds of foster kids that are on 5-6 medicines, because now every one of these symptoms, whether it's normal or even if it's abnormal, becomes its own psychiatric disorder. So the kid can't focus, so the kid has ADHD. The kid is sad and unhappy. The kid has depression. The kid's worried. The kid has anxiety disorder. And the kid's angry, so the kid has DMDD and misbehaves. And now the kid's on 4 different medicines, one medicine for each of those psychiatric disorders. Now, even if the kid has one disorder, those other sets of symptoms that might suggest other disorders are really secondary to the primary disorder. So I'll just give one example, but it could go in either way. If a kid has ADHD and is doing poorly at school, doing poorly in the foster home because the kid can't obey rules, because the kid can't follow instructions, has no friends because the kid is hyperactive and impulsive, and doing poorly at school because the kid can't focus and again is disruptive and impulsive, that kid is going to be sad and unhappy about not fitting in. That kid is going to be anxious about school performance. And that kid's going to have lots of disruptive behavior and difficulty regulating his or her mood. So most kids with ADHD also have mood dysregulation. So in fact, there's evidence that if you only treat the ADHD without doing these cocktails of multiple medicines for multiple diagnoses, over time, if the ADHD gets better, the anxiety gets better along with it, the depression gets better along with it, and the mood dysregulation gets better along with it, which actually should be expected because they're caused by the untreated ADHD. Or you could flip it. Kids with depression and anxiety can't concentrate. So that doesn't mean they have 2 different primary psychiatric disorders, both of which need treatment simultaneously. It means the depression is primary and the ADHD-like symptoms are part and parcel of the depression. You treat the depression and the ADHD-like symptoms get better. So this idea of multiple diagnoses, many of which are misdiagnosed. And once you do that, it's like a restaurant menu. You have 4 different disorders, so you get it on 4 different medicines, one for each disorder. Other causes of multiple medications is lack of psychotherapy, lack of other services. There's huge evidence that intensive wraparound services are highly effective, and lack of appropriate placement. Kids are thrown into residential settings where the evidence is absolutely clear-cut they would do better in a home setting with very few kids and wraparound services. But it's just easier to throw them into a residential placement, and that increases. In fact, as overused as medication is in foster homes, it's even more overused in residential placements. Over a third of kids, once you get out of infancy in residential placements across the country, are on psychiatric medicines. And lastly, and it's really poor treatment decisions on part of the provider. And part of that has to do with this culture of mislabeling normal, albeit intense emotions, misdiagnosis and multiple diagnoses, but it's also caused by who actually is your client. And if you're an adult psychiatrist, you're seeing folks paying out of pocket or their insurance is covering your treatment, the decision is clear. It's the adult with the advice of their provider. But with kids, it gets way more complicated because kids don't pay, the parents pay. So therefore, what the parents want, you don't want to disappoint too many of the people that pay you, because then you're not going to make money. And unfortunately, that influences decision-making. And nowhere is it worse than when you have kids in juvenile justice and foster care, because then either the state or the foster care or juvenile justice agency are paying you, and they're demanding medicine. If you constantly say to them the kid doesn't need medicine, they're going to find a different provider. So ultimately, the person that pays you has inordinate influence on your decision-making. And kids are not the clients, although legally, ethically, and on paper they are, in the real world they're not, because they're not paying. The state is ultimately paying, either through a private contracted agency or directly through their Department of Social Service. So all of this leads to tremendous overuse of medication. Last thing is, as a society, we want the quick fix. So we'd rather make the kid into a zombie than take the 12 weeks it might take for psychotherapy to really have good effect. So why don't I break here and we could answer a few questions.
It sounds great. There's one in the chat that says, I'm told that for kids in foster care, foster parents get more money if the kids are on medications, and that foster parents have been told this and are encouraged to have the children put on medications.
That's absolutely true. It's true in many of the jurisdictions I've consulted with, and that's just another of, again, it's lack of advocacy. Or the word, again, most of the demand for medicine is coming for the foster parents, either because they want more money, which they do get if the kid is in medicine, on medicine, or they just can't tolerate the behavior, which they would tolerate if it was their natural child. There's a limit, So that absolutely is true. There is financial gain for foster parents demanding medicine.
Thank you. That's the only question that I see in the chat at this point, but we'll break at the next section break. So if anybody else has questions, please put them in the chat and I'll make sure that I feed them to Dr. Irwin.
Oh, and the last thing, which is a cause, but I devote a whole section to that later, is lack of true informed consent. Either there is no consent required or it's garbage in, garbage out, coerced. And I will talk more about consent later. So now I want to switch and really talk about when should you be suspicious, or at least what things should raise your concern that the kid's you're representing or the kids of parents that you're representing may be getting inappropriate medication. And all of this is in the handout, which you can print out and keep for the future. So first and foremost, it's medication cocktails, use of multiple medicines. Once a kid in the systems we're talking about is put on a single medicine, probably on average close to half of them are then put on multiple medicines. I've seen many, many kids on cocktails of 4, 5, 6 medicines. I saw one kid, the record I've seen was a kid on 11 medicines. The kid was only 8 years old. Luckily, I was able to call in some favors and get that kid admitted to Bellevue, which is probably one of the best public hospitals for child psychiatry in the country. Even though he didn't meet the criteria for admission, their chief of service, who's a close colleague, agreed, there's no way to do this as an outpatient. And within 4 weeks, they reduced this kid to 5 medicines at lower doses, and then more even once the kid left home. 11 medications. 8 of them were classical psychiatric medicines. 3 of them were pediatric medicines to treat the side effects of psychiatric medicines. But it's, there really is no indication that I could see for that many, for really the use of multiple medicines. Most kids could be stabilized on 1 medicine. Occasionally, there's a kid who requires 2 medicines. For short periods of time, as you might be tapering, lowering 1 medicine and initiating a new medicine, there's that overlap period where you could be on 3 medicines. But the amount of medicines these kids are on is outrageous, and it really, the harm way outweighs the benefit. So somewhat arbitrarily, because when I initiated the reform in New York City, if you go after flagging in a system that's been over-medicating, if you go and you change the policy, you can't flag all the kids at once because you don't have the resources. So we had to put in some arbitrary limits of who should get priority for being reevaluated. So any kid in 5 or under, any kid in preschool, any kid in pre-K, any young child who's put on any psychiatric medication, that really should be a red flag. You should consider that as possibly being inappropriate. There are preschool kids that do need medicine, but that's very, very rare. The treatment of choice for young children is therapy. And the therapy really should, the proven therapy for kids in this age group is parent-child dyadic therapy that has lots of different names. The version NYU does is called parent-child therapy, but it's basically seeing the child and a parent together and using the therapy as a laboratory where the parent learns the role they're playing in eliciting the maladaptive behaviors, like not listening to the kid, not communicating properly, not understanding the kid's trauma All of this has to be trauma informed. You use the therapy as a laboratory for the parent to learn how to communicate better with the child learn to communicate better with the parent, building a stronger, mutually satisfying relationship. And for that, the parent does deserve to get paid more because it's asking for a time commitment. Giving a kid a medicine doesn't involve a lot of extra work for a foster parent. Doing evidence-based parent-child therapy does involve a true time commitment and should be, and that parent then has less capability of having a full-time job, a part-time job, and should get a higher rate. But therapy, evidence-based therapy is by far the treatment of choice for preschool kids. Special ed preschool in many jurisdictions, kids are eligible for intensive services through the state health department before they're age 3, after they're age 3, even if pre-K is not mandated in that jurisdiction. Special ed services are mandated. So you ask for an IEP for a school, school district-based evaluation, and you get services through the school. These have, and again, home-based intensive wraparound services are highly effective. So no preschool kid, and I'll put it there, any preschool kid that medicine is recommended, it really should not be the treatment of first choice. So that's the red flag. For school-age kids, the first medication, even if it's an ADHD medicine, may be indicated, but the concern then is when you add the second medicine. For middle school kids, it might be, you should really look into it and consider going to court or demanding a reevaluation, adding the third medicine, and for a high school kid, adding the fourth medicine. Although in the ideal of all worlds, if more services were readily available, I would lower those boundaries. But little kids on any medicine, older kids on multiple medicines should be the first red flag for you to, really consider that there might be a problem. Second is, and you'd be surprised how you all could judge this if you start thinking about it. So again, I wouldn't make a big deal of a 10-year-old being put on an ADHD medicine, even by their pediatrician, because we don't have the resources as a country to do this better. But what you all should demand is that there's evidence after 2-3 months that the kid is doing better on that medicine. And if you can't find any evidence that the teachers are saying the kid is much better, or even when you see the kid in your office or the parent sees the kid in the visit, you're really hard pressed to see that the kid is better, then you should raise the question. It was reasonable to try the medicine, but it's a red flag. Why are we continuing the medicine if it's not working? Especially for the population we're talking about, we don't differentiate between trying a medicine and prescribing the medicine long term. So when my cardiologist gives me a blood pressure medicine, my cardiologist will demand to know, has that medicine lowered my blood pressure? And if that medicine hasn't lowered my blood pressure, the cardiologist is going to stop the medicine and try a different medicine. That's what we should be doing with these kids. If the first medicine doesn't work, we shouldn't add the second medicine. We should stop the medicine that's not working and try a different medicine. Just like my cardiologist would do for my blood pressure. or your GP does if they put you on an antibiotic and after 10 days, if it's not working, they stop that antibiotic and they try a different one. And that's how kids end up on these 4 or 5 medicines. The first medicine isn't effective, but the provider says it's partially effective. I don't know what that actually means. The medicine really is reasonably effective, that it's helping you or it's not. Partially effective really means it's not working. So then they add the second medicine or the third medicine. So adding a medicine when a medicine is partially effective is a red flag. Adding a medicine to counteract the side effects of the first medicine is a red flag. So if a kid is on a stimulant for ADHD and is having insomnia, you don't add a sleeping pill. You try behavioral measures for the insomnia. If that doesn't work, you then try a different stimulant. Just because Concerta caused insomnia doesn't mean Adderall is going to cause insomnia. Or you actually add a low dose booster of the same medicine, but the short acting version. So if the kid's having insomnia on high dose Concerta, but is getting a really good response, not a partial response, but the side effect doesn't go away, you add a tiny dose of short acting Ritalin, which is the same active medicine as Concerta, at 5 p.m. And that likely smooths out coming off the Concerta and the insomnia goes away. You know, it's fairly rare that you can't find a different medicine where you could successfully treat the kid with one medicine without the side effect. And it really is, I think, poor clinical practice to add a medicine to cover over a side effect. Anytime a kid is started on 2 medicines at once, that should raise your concern. Why start a kid on 2 medicines? How do you know that one medicine's not going to work? So the kid in the paradigm I gave as part of the causes. So the kid has ADHD-like symptoms and the kid has depression-like symptoms. Why start the kid both on an antidepressant and a stimulant for the ADHD? Chance the kid has 2 separate primary independent disorders is very, very low. It's much, much more likely that one of those 2 disorders is primary, that the kid has ADHD and that's causing the depression, or the kid has depression and that's causing the ADHD. So you don't treat both on day 1. You pick which you think is primary and you treat it. And if that doesn't work, you maybe then change strategies and pick the other disorder and treat that. And only when you could say with certainty, the ADHD medicine helps the ADHD, but not the depression, anxiety. The antidepressant helps the anxiety, depression, but doesn't help the focus or the squirminess. Then you know the kid needs both medicines and you go back and you add the one the kid's not on. But to a priori say the kid needs 2 medicines, A, increases the chance that the medicine won't work because the medicines do interact with one another. B, it increases the chance of side effects. C, if the medicine works, you don't know which is working, so you end up keeping the kid on both medicines forever. And D, if the kid has side effects, you have no idea which medicine is causing the side effects because you've tried the 2 medicines simultaneously. That really is bad practice. The other variation of that is trying 2 different ADHD medicines at the same time. So the kid's put on a stimulant, which is the mainstay of treating ADHD, but the kid is also put on an alpha agonist, which is clonidine, guanfacine, 10X, Capve, or Intuniv, which is a effective ADHD medicine, but works exactly in the opposite manner of the stimulant. And the rationale for doing that is the stimulant will help the focus, the intuitive will help the behavior and the sleep. But again, 70 to 80% of ADHD kids will respond to one of those medicines or the other. Only a small fraction needs both those medicines. There are kids that clearly do need both of them, but you don't know that on day one. So why put a kid on two medicines? So that's another red flag. Off-label prescription. Off-label, actually, let me backtrack a second. As you might know, if you followed all the COVID medicines, the way medicine gets approved in the United States is you do a study that's called double-blind, which means that you give half the people active medicine, you give half the people sham medicine. You try to make sure as much as possible that those two groups are equal. And then after X number of weeks, you measure the effectiveness of the active medicine and compare it to the effectiveness of the sham medicine. And you compare the incidence of side effects with the active medicine and the sham medicine. And if the active medicine is safe and way more effective than the fake medicine, the FDA, the federal government's Food and Drug Administration, approves the medicine for use in a specific population for a specific indication. Off-label medicine means the medicine hasn't been approved for that population or for that indication or both. The biggest problem with off-label medication is with the antipsychotic medication. Medicines that are effective treatment for bipolar disorder and schizophrenia in adults. And that's Abilify, Seroquel, Risperidone, Zyprexa. Those are the main ones you probably heard of, but it also includes Thorazine and some others, Haldol, which you may not, which are used less these days. They're given to kids with mood dysregulation. And what mood dysregulation means that they get angry really quickly and have bad tempers, and they go from 0 to 10 in 2 seconds. And their mood changes minute to minute, hour to hour, usually because of triggers that you can't identify, even if they're maladaptive triggers. Somebody presses their button and they explode. So they don't regulate their mood appropriately. And that is a serious symptom. It's developmental because they've never been taught how to regulate their mood. It's something we learn to do. And if you've been exposed to trauma, it's harder to learn. And if you've been in the system, there aren't adults to really teach it to you. Usually it's taught to you by your parents as part of a loving, mutual back and forth relationship. So there's lots of reasons why these kids have why they have mood dysregulation. So we then pathologize it and say they have a mood disorder. And then we treat them as if they have bipolar disorder, which is the most significant of mood disorders. But depression is also a mood disorder, which has way safer medicines. And lots of times why kids have dysregulated mood is because of untreated depression and trauma. And kids with ADHD, as a second, frequently have mood dysregulation. So instead of evaluating these kids very carefully, and if need be, treating them for untreated ADHD, untreated depression / anxiety, or untreated complex trauma or PTSD, we now say they have mood disorder, i.e. a bipolar lookalike, and we now call that DMDD, disruptive mood dysregulation disorder. So we've over pathologized mood dysregulation, and that's akin to bipolar disorder, and we treat them with the most risky of psychiatric medicines, the antipsychotic medicines. There's not a single shred of evidence that these medicines work for mood dysregulation. They do work even in kids for true bipolar disorder or schizophrenia, but there's no evidence they work for mood dysregulation in kids. And they're the most risky of the as a group of any of the psychiatric medicines we're going to talk about. They cause significant weight gain. We're talking about gaining, 10, 20% of your body weight in a matter of months. We're talking about tremendous increase of the risk of developing type 2 diabetes, both from the weight gain, but also independently of the weight gain. We're talking about sedation, so you can't learn at school. These kids already on average are years behind at school. Our task should be to find treatments that help them catch up developmentally, so there's at least a hope that these kids could become fully functioning adults. You cannot be a fully functioning adult without an education. We're taking kids who are years behind and we're sedating them to make them fall further behind. I think that's unethical. We've taken away any hope that these kids could become fully functioning adults. No kid should be on an off-label medicine unless every single reasonable alternative has been tried, including non-medical therapies and safer medicines. So if I have a kid who really has terrible mood dysregulation to the point of being dangerous, I want to avoid hospitalization, I want to avoid the kid getting kicked out of their foster home. I've really looked and I don't see untreated ADHD, I don't see true depression or anxiety disorder, but you have to do something because psychotherapy takes time. I'll put the kid on Intuniv, the medicine I mentioned previously, because it really works for this mood dysregulation. It dampens that hyperarousal, overreactivity, overstimulation. And although it's used off-label, it's on-label for ADHD, it's off-label for these kids we're talking about now, but it's also the safest psychiatric medicine around. It essentially has no side effects, except for slight sedation, which tends to be minimal and goes away. And you do have to just start slowly and build up slowly, because Intuniv, clonidine, 10X were originally developed as blood pressure medicine. So it does lower blood pressure. So you just don't want to drop the kid's blood pressure out, which is, even with bad practices, almost impossible to do because kids have highly elastic blood vessels. But to be safe, you start the medicine low, build up slowly. If their baseline blood pressure goes a little bit lower, even though that's considered a side effect because that's not what you're treating for, that's actually a protective factor. It protects against later heart disease. So you haven't harmed the kid by lowering their baseline blood pressure a few points. So, if you have to do something off-label, you go with the safer medicines, and antipsychotics are probably the most abused psychiatric medicines in the systems we're talking about. Why don't we stop here for some questions, and then I'll give a few very specific clinical guidelines for very specific things. Any questions?
Yeah, so doctor, in the chat, someone had asked if there's a good reference or book on the medications that you mentioned, something like the DSM to help lawyers flag when meds are being prescribed inappropriately.
Not really, because whatever's out there is really is based on treating white middle to upper middle class kids living with their families. And like I said, kids in the systems we're talking about might present with some overlapping symptoms, but they're very different. So the kid, who's feeling sad out of the blue is different from the kid who's feeling sad because he was dumped in foster care and never sees his parent or siblings or friends. The kid that's worried that mom's going to not be alive because the boyfriend's beating her up is different from the kid in school who is worried that, mom's going to get hit by a car when that's never happened to anybody in the family. It's, it's an obsession. Treating symptoms of trauma is different than treating the same symptoms that are not part of trauma. Mood dysregulation in a kid who's never experienced significant adverse family or life circumstances might actually be bipolar disorder, where in the kids we're talking about, it's almost never bipolar disorder. So in some ways, these red flags are things you could use to evaluate we've developed, at some point it's going to be, and I don't know if it's on a public, I developed consent forms that are medication specific. So there's a different consent form for every single medicine. I developed consent forms for ACS that really are handouts about each separate medication. And at some point that's going to be on a public facing website. I don't know if they've quite gotten there yet. And those handouts, as we'll talk about in the consent section of the talk, are given to all parents, which they could share and should share with their advocates.
Thank you for that. Is there somewhere we could go to see routine side effects like you had mentioned?
They're all in the consent forms.
They're all in the consent forms. Okay.
Very specific. So they really give you a way of judging, is the medicine effective, appropriate, et cetera, et cetera. Do the risks outweigh the benefit? And the consent forms have multiple alternatives for any disorder. Again, there's never one alternative. There's medicine, but within medicine, there are safer medicines, on-label medicines, less safe medicines, off-label medicines, and a safe on-label medicine always trumps a high-risk off-label medicine. Psychotherapy is always offered as an alternative. So again, it talks about the alternatives, and it doesn't matter if that's the first choice of the provider.
Mm-hmm.
I would hope when all of us see providers for anything in medicine or surgery or mental health, yes, we want to know the provider's opinion about what they think is the best alternative, but they're going on a different value system than we are. And when I choose treatment for me, it's based on my value system, how I weigh effectiveness versus risk, how risk averse I am, any religious or family beliefs or community or individual beliefs I have. yes, there are some treatments that are unreasonable. I would suggest, although I haven't really reviewed the literature all that well, that ivermectin is not a reasonable choice for COVID. But there are multiple reasonable things, and sometimes watchful waiting is a reasonable treatment. And we don't have to pick the treatment that's the number one choice of our provider. And the provider is obligated to give us all the reasonable treatments and the pros and cons of those reasonable treatments. So if I was seeing a orthopedic surgeon and they were recommending spinal surgery for me, even if that was the most effective treatment, I have the right to say I'd prefer to be in extra pain to not take the risk of ending up in a wheelchair. That's a reasonable choice. And as an aside, so I'll mention it now until later, I've reviewed hundreds and hundreds of consent forms for kids in child welfare, and 95% of them don't give any alternative. I've recommended this, and if you don't follow this, it's medical neglect. And again, the subtle or less than subtle coercion. So the forms we developed are developed specifically for child welfare.
Well, it's exciting to think that they're going to be outward facing. We'll be able to see them.
And they are used in New York City now, and they should be, sooner than later. But we're talking about a vast bureaucracy on a public, facing website.
Okay, well, keep us posted, because I think there's lots of people on here who would like to see them. Someone had placed in the chat, what about drugs.com, just looking for side effects? If you find out your client is being prescribed a certain medication, do you have an opinion on drugs.com?
Again, but it's basically for adults, just like it's basically for adults, and it doesn't put anything in context.
Okay, thank you.
Sedation might be listed as a side effect, but sedation for the upper middle class kid who's in a private school and 2 years ahead is different than sedating a kid who's 4 years behind in school. It needs to be able to read, write, and do arithmetic to have any prayer of ever getting a job.
Thank you for that reminder.
So I want to talk about a few more red flags. One is very controversial, but I really believe in it, and I'll say it, and I'll give an example. Nurse practitioners, psychiatrists are very expensive. Child psychiatrists are very few and even more expensive. So the bulk of first-line mental health care, including prescribing, is done by nurse practitioners. But if a kid has failed multiple treatments, or a kid has done so poorly that they're now in residential care, which is basically licensed as long-term nursing care, almost, or a less intense hospital care than an acute hospital. Those kids should be seen by a child psychiatrist. And the example I would give to emphasize my point is, again, nurse practitioners prescribe blood pressure medicines. And that's absolutely reasonable. But if you failed 3 or 4 blood pressure medicines, you should see the cardiologist. And in our system, that doesn't happen. In residential care, you tend to be seen by nurse practitioners. When you go to community mental health centers, you're seen by nurse practitioners. And any kid that's failed multiple medicines, multiple treatments, or is doing so poorly that they're in what's considered a higher level of mental health care, they should be seen by child psychiatrists. Next, I want to talk about any kid that's gained massive amounts of weight. That's a red flag. And especially the antipsychotics cause significant amount of weight gain. I ask this rhetorically because I know the answer. When I used to do live presentations, I used to sort of ask people to sort of raise their hands, even though I knew the outcome. If you were put on a medicine for a non-life-threatening situation and you gained 5 or 10 pounds, you'd be quite unhappy. If you were on the compliance side, you would go back to your doctor and say, isn't there something else I could take that won't make me gain weight? You might even complain, why didn't you tell me about the weight gain? Because if not, I wouldn't have agreed to this medicine. And if you're on the non-compliant side, you might stop the medicine on your own or just go to a different doctor. Nobody in the systems we're dealing with, if we make the kid into a zombie and the kid's not doing things to aggravate the adults, we don't care if the kid has gained 5 or 10 or even 20 or 30 pounds. And even that is a little deceptive because if you gain 10 pounds, you're gaining 7% of your body weight because you've started out at 120 or 140. A kid, a 10-year-old who's gained 10 pounds has gained 30% of his weight because that kid's only starting out at 50 pounds. If you gain 10 pounds, you might be overweight, but the kid that gains 10 pounds is obese because they're starting out, and we routinely ignore this. I can't tell you how many parents I've seen who said, I don't want my kid on this medicine because the kid is overweight, I'm overweight, I have type 2 diabetes, my mother has type 2 diabetes, my sisters have type 2 diabetes, and the kid already has signs of pre-diabetes, partly because of the obesity. And the medicine's given anyway. Anytime a kid is overweight or gaining significant amounts of weight, you really need to question that medicine and question whether there's an alternative. Two specific clinical situations should demand immediate attention. One is adolescent girls are put on Depakote fairly frequently for mood dysregulation, which they do have, and frequent sexual activity, which is mislabeled as hypersexuality, which is a sign of bipolar disorder. So the clinician is sort of saying, you know, I've always suspected bipolar disorder because of the mood dysregulation, but now because of the hypersexuality, it's definitely bipolar disorder, and they put the kid on Depakote, which is a medicine for adult bipolar disorder. Now, that is a gross misunderstanding about what hypersexuality as a psychiatric symptoms mean. Adolescents, as you probably remember, are obsessed with sex, more or less on the more side. My son has given me permission. He's in his 40s now, and he knows I talk about him in some of my talks. He was interested in having a lot of sexual activity as a teenager, but he was able, somewhat successfully, on the more side, to put a brake on that because he knew that if he was a father at age 15, that's not something he wanted. That would interfere with realistic goals that he set for his life. So there's at least some countervailing impulse to not act on your sexual impulses. And he also knew about safe sex and how to practice it. And lastly, he had something in his life called adult supervision, which is not perfect, but really is amazingly needed if it's done as part of a loving relationship to have healthy teenagers. Now, the adolescent girls we're talking about are hopeless about their future. They don't have overreaching goals that they want to attain. They actually, at least for some of them, think having a baby might be fun because they're so unloved. They feel that having a baby will give them the unconditional love they've never gotten. And they have frequent sex because the act of sex makes them feel they're getting the love they haven't gotten emotionally, even though at the end it's just sex. And these girls are less likely to practice safe sex. And you'll understand why I'm talking about girls in a minute. And they're also in the highest fertility rate of their lives. So lo and behold, we shouldn't be surprised that the incidence of pregnancy in girls in this population is much higher than we'd like. Now, that is not hypersexuality. That's not a sign of bipolar disorder. That's a sign of normal preoccupation with sexual impulses, which is normal to teenagers and is partly biological because of the tremendous increase in hormones. And it's because of another disorder called under adult supervision disorder, which isn't in DSM-5. These kids don't have the adults to supervise them appropriately and give them the context that might help them, that might be at least a counterweight for them not to have frequent unprotected sexual activity. So this is not hypersexuality, it's normal sexuality. Again, the behaviors of frequent sex with frequent partners might not be the most adaptive thing on earth, but it's not a psychiatric disorder. They don't have bipolar disorder, they're put on Depakote. Depakote is the single most dangerous psychiatric medicine for pregnancy. It causes, in a high percentage, fetal abnormalities and then birth abnormalities. No kid should go, no adolescent girl should go on Depakote, even with true consent, unless they and their parents are willing to have an abortion should they get pregnant. And this isn't something we should be pressuring kids to do after the fact. And in fact, even wealthy parents that I've treated their adolescent daughters who have true bipolar disorder, who believe in choice, who think abortion is an option, they don't consent for Depakote because they say, if my daughter got pregnant, I would consent to an abortion, but why would I want my kid to have an abortion? Let's find a safer medicine in case my kid gets pregnant. And here we put adolescent girls on this without telling them that they might need an abortion, without talking to their parents, if their parents would even, be willing to consider it, for a large part of our population, and we have to respect individuals' right to make the choice. They think abortion is against their religion or or shouldn't be done, and they have the right to their opinion. And we're putting girls, adolescent girls who have a high chance of pregnancy on a very dangerous medicine when other medicines don't have that higher risk for pregnancy complications. And at the end, I've seen most of these girls end up getting abortions, but we've subjected them, an abortion still involves some trauma. It's not totally benign. And there's what's way safer. So why should we use a medicine that's first inappropriate because these kids don't have bipolar disorder and is the most risky medicine for pregnancy in girls that have a high risk of pregnancy? Makes no sense to me. I think it's absolutely unethical. Next scenario, which I think requires immediate action on your part, is kids put on lithium who then develop some thyroid problems and they're put on thyroid hormone. Lithium can cause thyroid abnormality. It can very slowly poison the thyroid so that the thyroid doesn't produce enough thyroid hormone. When caught early, if you stop the lithium, you haven't done any harm because the thyroid hormone hasn't even gone low enough to cause thyroid negative effects. And if you stop the lithium, it's totally reversible. And yet, I see the lithium continued and thyroid hormone is added to make up for the thyroid slowly not being able to produce enough hormone on its own. Now, an adult could make that decision. An adult could say, I truly have bipolar disorder, which is the only indication for lithium. I've taken lithium for years and I know it's highly effective for me. I'm willing to sacrifice my thyroid. I'm willing to take thyroid hormone for the rest of my life. Thyroid hormone, the pill is as good as the real thing, very different than insulin or diabetes. Thyroid replacement, if you take it, is absolutely as good as the real thing. They're saying, I know I could afford the thyroid hormone, and I know I will monitor to make sure I'm getting the right amount of thyroid hormone. They could make a rational choice that stopping the lithium and saving the thyroid gland is a by far riskier decision than staying on the lithium and taking thyroid hormone for the rest of their life. Because if you stop the lithium and try an alternative, it might not work as well. So there, but how dare we make that decision for kids? First, it's unlikely the kid has bipolar disorder. Second, it's unlikely the lithium really is working. It's part of a cocktail and the kid's not doing well anyway, and somebody's afraid to stop the lithium because somebody in the past said it was partially effective, or because someone in the past said the kid had bipolar disorder. So it's the wrong medicine, it's not effective, and we're making a lifetime decision that could have a terrible negative effect on the kid's future. As long as the kid's in foster care and forced to take the thyroid hormone, the kid won't have any ill effect. But how do we know this kid's going to be a functioning adult? How do we know they're going to take the thyroid hormone when they're adults? If they end up homeless, they're not going to take it. They might not take it. How do we know they could afford it? How do we know that they'll have insurance that will help them afford it? How do we know they'll be willing to 4 times a year go to the doctor and get their thyroid levels measured so you could adjust the right amount of the hormone? Yes, optimal replacement of thyroid hormone is fine, but if you don't have it and the thyroid is irreplaceably done, you're going to be really sick with hypothyroid disease. And how do we make that decision for a kid? because this isn't going to be just while, this is going to be for the rest of the kid's life. This kid's going to have to take thyroid hormone. If you stop the lithium, the minute you have the early warning signs, the thyroid problem disappears. So those two things, I think, are things you really need to strenuously object to. Any quick questions about what I said?
Yes, we have some specific questions. So there's a question about side effects for Risperdal antipsychotic. So is gynecomastia a side effect of other medications besides Risperdal and antipsychotics?
Gynecomastia occurs most frequently with Risperdal, but it can occur, but very, very, very rarely with some of the other second generation antipsychotics. And I'm glad you mentioned that, because that is a serious side effect, but I wouldn't give Risperdal or the other stuff anyway, because of the much more common side effects, the massive weight gain, the risk of type 2 diabetes, the sedation where the kid is unable to learn at school. And like what I said with lithium, gynecomastia or milk leakage for girls is totally reversible if caught early. The problem is, and I've seen 3 boys that required surgery because nobody, the adults knew the boys' breasts were getting bigger. They didn't seem to tell, they didn't tell the provider. The provider never examined the kid. The provider didn't ask the kid, and sometimes the kid's too embarrassed, even if the provider asks. And you really need to send the kid to the pediatrician, where the provider routinely takes the kid's shirt off. But it is totally reversible if caught early, and there's no reason not to catch it while it's still reversible.
So one more question that we had in the chat was, you mentioned that nurse practitioner scripts are a red flag. What about physician's assistant writing scripts? And what about teaching hospitals and scripts written by residents? Do you need to make sure that an MD has reviewed them all?
In most teaching hospitals, residents really are closely supervised. Of all those scenarios, that's by far the least of my concern. Child psychiatry residents have already completed adult psychiatry training and are board certified for adult psychiatry. So I'm not particularly concerned about that. But I still would ask the questions. If a child psychiatry resident had the kid on 4 medicines, I still would ask the question. I'd ask that of an adult, of a child psychiatrist in practice who's board certified, if the kid was on 5 medicines, or the kid's really having, again, like I said, even a child psychiatrist, even if board certified, might be overly influenced by the caseworker and the foster parent or the teacher or the residential staff demanding the medicine and then presenting a skewed picture of the kid. I would absolutely be asked. I didn't mention PAs because I haven't seen, and it might just be because of New York, I haven't seen PAs really prescribe a lot of psychiatric medicine for kids. But yes, I'd have even more concern about the PA than the psychiatric nurse practitioner. PA has way less specific training in kids and medication.
Thank you for that. Those are all questions.
Few comments about consent red flags. The major red flag is only one alternative, no alternatives are provided. It's this consent says, your son, Johnny, date of birth, has depression, and I'm recommending Prozac as an antidepressant. No alternatives given, like psychotherapy is as good, if not better, a treatment for depression. Second, a global statement of effectiveness is made. Your child has depression, and Prozac is an effective treatment for depression. That's true, but it's grossly misrepresented to the point where it really is more of a lie than the truth. Does Prozac help 100% of kids who are depressed? 70%, 50%, 30%? What percent are helped by sugar pills, which is important. So Prozac helps about 70% of kids that try it, but 35% of kids that try sugar pill get as much benefit as Prozac, which means that biologically Prozac helps maybe about 40% of kids, which is which means it's a decent response, but yet if you treat 10 kids with Prozac, 4 get better because of the biology of Prozac, 4 get better because of the placebo effect of Prozac, but they would have gotten better anyway, and 2 don't get better at all. That's a very different statement than saying Prozac is an effective treatment for depression. Again, if you were offered 2 treatments and your doctor told you these are both effective treatments for whatever, for your skin cancer, and then didn't tell you that one of those treatments is effective 80% of the time, the other treatment is effective 20% of the time, which would you choose? Therapy is effective close to 80% of the time. There might be a placebo effect with that too, but less powerful probably than the medicine, and at least there's no risk. So a global statement about effectiveness is a red flag. The side effects don't include or focus on the black box warning. So frequently the side effects will give the annoying side effects, but not the rare but very serious side effects. Like 1 out of 5 kids on an antidepressant might become manic. Like 30% of girls, adolescent girls who become pregnant are at risk for significant fetal abnormality. And the black box warnings are something you could look up on the web for every single medicine. There's no discussion, even if alternatives are given, there's no discussion of the benefits or risks of the alternatives. And probably the most important is the parents didn't speak with the prescriber, didn't meet with them or even speak with them. Probably 40% of the consent forms I've seen are generic to the clinic that's given it, and they have the audacity, and I think this probably is illegal, it's definitely unethical. So they send the DSS caseworker a consent form saying, I've spoken to the parent and explained all the benefits and risks. The caseworker has the parent sign with this. The parent has never spoken with the provider. And some bean counter says, look, we have a 100% rate of parental consent. That I think might be illegal. It's definitely unethical. Anytime a consent is signed without the parent having at least spoken at length to the provider is by definition invalid. And I also think, although legally it's way more vague, you need assent on the part of the child. You can't treat successfully with a non-compliant child. Now, some kids feel they need to save face, so they initially say no. You try the medicine and the foster parent says they've taken every single dose. You see them after the first time and they say, I really want to take this medicine now because it's really effective, or at least they say, I notice it really is effective. But if a kid really doesn't want to take the medicine, they shouldn't be given it, because non-compliance means that they'll either end up being overdosed, because so then the foster parent takes them back and says, the kid has taken 40 milligrams of Prozac, it has no effect, when in reality the kid has taken none. So the clinician says, oh, now we're going to raise it to 80, not knowing that the kid hasn't taken it and not caring that the kid basically says, I'm not taking it because the parent, and then you could get into an overdose because the kid really hasn't taken the dose that you think the kid has taken when you raise the medicine. And lastly, if you miss enough doses, the medicine can't possibly be effective. And the minute the kid leaves care, the kid's going to stop the medicine. So you haven't helped the kid. So if you treat the depression by teaching the kid coping skills, what to do when they're depressed, the kid still could use that when the kid leaves care. If you give the kid the antidepressant and the kid leaves care and stops taking it, you haven't really helped the kid. So I think assent is a huge issue. Why don't we stop here? And again, questions either about consent, but also, any, discussion about issues that are raised or.
I don't see any questions in the chat.
So why don't I end? What are some possible solutions? From the psychiatric end, there should be dedicated clinics and centers of excellence. Because again, even board certified child psychiatrists, if they haven't treated enough of these kids, they're going to misjudge these kids based on the templates in their head from kids that really are under very different life circumstances. Even if they've, now, even in a dedicated clinic, or maybe even more so in a dedicated clinic, there might be initially the pressure from the caseworker, DSS, OCFS, the school, on the provider, because that's a dedicated clinic where the psychiatrists have had huge experience specifically with this population. A, they could withstand that pressure. B, they have a much better knowledge base of what the kid really needs. And as part of that dedicated clinic, they could teach the foster parents, the caseworker, the teacher, the DSS worker, why they are doing something different from what they wanted. And education really does empower. After multiple caseworkers, when the caseworker, somebody has sat down with them and talks about why risperidone is not a good treatment for the foster kid's anger, they'll get it. And they won't even be demanding it anymore. Or even before they bring the kid to the clinic, to the dedicated clinic, they will have put the preschool kid in parent-child interactive psychotherapy. So dedicated clinics really tremendously reduce the overuse of medication. Training, both providers, for child welfare workers, for lawyers, help. True informed consent, like we're trying to do in New York City. Policy reform, like we did in New York City. Demanding consultation, and judges, they might not order a medicine stop, but if you go in and say, this kid has been on 5 medicines, has failed all of them, has only been seen by a nurse practitioner, I really want the kid to see a doctor. The average judge will, and give the, in fact, the example that they could understand of a treating high blood pressure. Because then you make it understandable to them. Then the foster kid isn't the other. It's the same problem they have seeking medical care for themselves and their families. They might order a one-time expert psychiatric review. And of course, litigation, both individual litigation, which changed the policy in New York State to require informed consent, and class action litigation, which forces states to change policy. So if there are any questions, if not, it's been a pleasure. If you ever, have any cases that you want a really quick, informal consult about, email me. I obviously can't, review records but if you just, give me a short vignette, I could give you some general comments on, do I think that's appropriate? What might be alternatives?
So we do have a couple questions. We have a question about the dangers of certain medications when there's a serious history of polysubstances known, such as Seroquel.
The medicine of most concern for this issue are the stimulants. The stimulants have huge potential for abuse. The stimulants are bought and sold on the street. They are used heavily to self-medicate. Slow dose Seroquel has a following. Seroquel is an antipsychotic. Again, I would have a concern about why you're using it in any kid. But Seroquel in low dose has a following because it takes the edge off, isn't abused nearly as much as the stimulants. But again, I wouldn't not prescribe that because of I just don't prescribe Seroquel much because the risks in general outweigh the gain. But you are right, for kids with polysubstance abuse, especially the kids we're talking about who have less than average expectable supervision, of parents really locking up the medicine, giving it to them, checking that they take it at the right dose. There is the alternative, even if they have full-fledged real ADHD, and that's Intuitive, which has no abuse potential. So very good question.
We have another that came up in the chat. It says, what about kids who are using street drugs or abusing prescription drugs?
Street drugs, luckily, in the ideal of all possible worlds, it's best if they don't concomitantly use the street drugs and the prescription drugs. But also in the real world, that's unrealistic. In any population, and especially the population we're talking about. So luckily, stimulants, it's not really dangerous giving stimulants to kids that are using alcohol or marijuana. And in fact, there's evidence that if they respond to the stimulant, you might be a little bit easier getting them off that stuff. Again, there's no real danger with the SSRI antidepressants, such as Prozac. And since, at least in part, street drugs are heavily used to self-medicate anxiety and depression, as kids respond, if they respond and as they respond to the Prozac, they might be more willing to cut down or even come off the street drugs. I wouldn't use Wellbutrin in a kid that was binge drinking. Wellbutrin is an antidepressant that also has ADHD effects, but is really contraindicated in kids with binge drinking, or with kids with eating disorders, or kids that have had seizures in the past. But luckily, Intuitive or clonidine or Capve, I would just be a little bit more careful in monitoring their blood pressure, because not so much the alcohol, but the street drugs might also be lowering the blood pressure. And then you might get an additive effect where you do lower their blood pressure too much. So again, I wouldn't hesitate using it if I was sure I had a foster parent or a residential staff that would monitor the blood pressure as needed. And again, a little bit more intensely than I would in a kid that wasn't taking the street drugs. If the kid is buying prescription drugs on the street, you do a drug-drug interaction, which you could get online, and they're highly accurate. And again, mostly what it would be is looking, again, for medicines that have really significant contraindications mixed with the medicine the psychiatrist is putting the kid on. But luckily, that's not, nearly as major an issue as the other things I've mentioned.
Thank you for that. I don't see any other questions in the chat, but I do see a lot of thank yous and a lot of platitudes that it was incredibly informative and helpful, and just appreciating you taking the time to come and talk to us today. Again, please join me in thanking Dr. Irwin for spending the afternoon with us teaching on this highly important topic. We'll be teaching again on April 25th and looking at it more through the lens of structural racism with Heji Kim and myself. And again, Dr. Irwin's email is in the chat if you have questions. And thank you so much, Dr. Irwin.
My pleasure. Bye-bye.